Good afternoon and welcome. My name is Steve Siebold. I work with Alberta Health Services as part of the Allied Health Professional Practice and Education team. I will moderate the session today. Thank you for joining us for this PracticeWise Lunch and Learn session. I guess we're not at Lunch and Learn anymore, hosted by Health Profession Strategy and Practice. The information provided is intended for an Alberta Health Services audience. Other groups may find the material applicable, but are responsible for aligning it with their own clinical policies and procedures. Please note that this session, along with the question and answer period, is being recorded. Every effort has been made to incorporate the best and most current evidence and information available. However, please keep in mind that new evidence and information emerges frequently, particularly with COVID-19. We're very excited to have such great interest in the session today. Because of the high number of participants, we ask that you please keep your audio lines muted. Please use the chat function to type in any questions. You can find the chat function at the bottom of your screen near the middle. Please use a direct message to questions. I will just send a message from that name so you can reply to it. I will collect the questions on behalf of our presenters and we'll do our best to answer them at the end of the session. If you have any trouble finding the chat or think of questions after the session, you can email those to practiceconsultation@ahs.ca. That's the same email address that was included on the webinar information page. Our session today is post-COVID recovery, physical sequelae, and screening. This is the first in a series of webinars. Webinars are designed to help healthcare providers address the biopsychosocial needs of patients as part of their rehabilitation programs and in supporting their overall recovery after COVID-19. We encourage all providers to tune in to as many of these sessions as possible to support a holistic approach to care. We will record today's session and post it to the Alberta Health Services public website, linked from the COVID-19 information for AHS staff and health professionals in the recovery and rehabilitation section. That's one of the links that's in the IM right now. We have also created a companion hard copy resource in a PDF format. It's a living document and will be updated as new information and content becomes available. It's currently only available to AHS staff through the internal SharePoint link. We'll work to post that to the public site in the near future. We're very pleased to have Lauren Singh presenting today. She's a physiotherapist with the Pulmonary Rehabilitation Program of Community Accessible Rehabilitation Services here in Calgary. Lauren has been working with a number of patients to develop rehabilitation programs to support the recovery and return to activity post-COVID-19. Also presenting today are Laura Bernard and Caitlin Troop. Both are physiotherapists and senior practice consultants who work on the Allied Health Professional Practice and Education team. With that, I'll pass it over to you, Laura.
Thanks, Stephen. Before we start, we do want to acknowledge that the content we'll be discussing today has only been possible due to the collective brainpower of many clinicians. We want to thank all the PTs in the working group, William Tung, Fern Lee, Heather Zeigen, Sarah Arsenault, Kira Ellis, the team at Community Accessible Rehabilitation in Calgary, particularly Andrea Pierce, Margie Haas, Safia Rahan, and their support in developing the screening tool. As many of the PTs, and additionally, many of the PTs, OTs, and RTs across AHS who provided feedback throughout this process. And finally, we want to thank many of the AHS physicians and specialists, colleagues at the U of A, Dr. Ellie Stein, Judy Kay, Lorna Nicholson, and Darren Brown for taking the time to meet with us as we work to develop these resources. As clinicians, you all have the training and skills to address a broad spectrum of impairments and functional needs. These sessions are meant to add to your critical thinking skills and provide you with the information to address the additional clinical considerations of a post-COVID patient. In this session, we will discuss the background work that has led us to this point. We'll talk about an overview of common post-COVID-19 symptoms, and we'll discuss the key considerations in rehab, including screening for and monitoring common physical sequelae. Throughout this presentation, the term post-COVID is used to capture patients in both the subacute phase of recovery and those experiencing long-term symptoms. But why are we talking about this? Just looking at Google on June 6, 2021, there were 212 million results on rehab post-COVID, 55 million on post-COVID rehab guidelines, and 4.8 billion on post-COVID in the news. So it seems like everyone is talking about rehab and post-COVID, but it's a bit overwhelming. But the unfortunate truth is that COVID inpatient and post-ICU patients will require rehab as they recover from the physical sequelae, as well as the implications of isolation and trauma. Additionally, approximately 10% to 25% of persons with COVID-19 go on to experience ongoing symptoms up to and beyond 12 weeks after diagnosis. So let's look at the Alberta numbers. You may recognize this graph. It was pulled from Alberta statistics on June 6th. As of June 5th, 2021, we had 9,414 patients hospitalized with COVID-19 and 1,742 have been in our ICUs. We know that COVID-19 patients who require an intensive care admission may have longer-term disability following discharge, and it is anticipated that COVID will result in significant morbidity for 3 to 6 months. But what about those long COVID patients or those long haulers? Estimates vary from 10% to over 25% of patients who experienced even mild COVID infections may go on to develop prolonged symptoms. Our total lab confirmed COVID cases in Alberta as of June 5th were almost 229,000 cases. A low estimate of Albertans experiencing post-COVID symptoms, 10%, is 23,000, while the high estimate of 25% is 57,000. That's a lot of Albertans. So what's being done? The post-COVID rehab strategy task force worked from summer and early fall in 2020 and had various working groups addressing screening, rehab practices, discharge, transition planning, and longitudinal monitoring. The post-COVID implementation task force working groups from November 2020 to March 2021 created the rehab screening tool, including the post-COVID functional status scale and a symptom checklist, a patient resource, and proposed a variety of pathways across the continuum of care. So you may have already seen the post-COVID functional status scale, which helps to identify the level of functional impairment a patient is experiencing from no functional limitations to severe. Additionally, a post-COVID symptom checklist helps to identify the types of symptoms after COVID that may be impacting a patient's function, from cardiorespiratory and neurological symptoms to musculoskeletal symptoms, as well as mood, fatigue, pain, nutritional considerations. The PCFS, along with the symptom checklist, has been recommended for use at hospital discharge or in the community to help identify where a patient should be referred for rehabilitation. This is the beginning of the primary care and community pathway for post-COVID rehab. As you can see, the PCFS score helps to identify the type of rehab from universal to targeted and personalized, but notes that all patients should receive information on self-management and symptom monitoring. The use of the symptom checklist can help further identify which of the services a patient may best be referred to, and currently work is underway to map out these universal, targeted, and personalized services at the zone level through our ECC task force. The ECC task force is the third in the process to understand, communicate, and implement services for Albertans post-COVID. And herein lies the work that we're doing as part of the required resources to develop clinician resources. Through many of our task force working group discussions, our practice council discussions, clinical team meetings, we have heard some consistent asks from clinicians. They wanted to understand what's different for a patient with post-COVID. They wanted to know when they could safely recommend activity or exercise. They wanted to understand how they could prioritize COVID patients in the context of their existing caseloads. They wanted to know what treatment parameters they needed to consider for a COVID patient. And finally, they wanted this information to be from a biopsychosocial lens because of the heterogeneous nature and the interprofessional needs of post-COVID patients. As a result, we're compiling a single resource document that will be out soon. Well, actually just posted now, the rehabilitation and allied health practice considerations post-COVID-19. And hopefully Stephen has added that link in the chat box. So let's talk quickly about the clinical presentation post-COVID. And a reminder that for our purposes today, we're using the term post-COVID to capture patients in both the subacute phase of recovery and those experiencing long-term symptoms. These symptoms reflect the general presentation that patients post-COVID may experience. For the most part, our treatments don't change, and our goal was not to recreate documents or treatment recommendations that are already readily available. Our goal was to focus on what is different for a post-COVID patient. As I said, all clinicians have the training and skills to address a variety of impairments and functional needs, and these sessions will just add to your critical thinking skills. But having said that, we've all seen the news and social media that there are some physical sequelae that clinicians who may prescribe, recommend, or address or support physical activity or exercise should be aware of. And with that, I'm going to hand it over to Lauren to discuss these physical sequelae and why they're important for us to understand.
Great. Thanks, Laura. So like Laura said, COVID-19 can present in a broad clinical way. It's multi-system and the endpoint is extremely varied, and the volume of impairments that we might say after the fact mirrors the same volume of conditions that we treat in a rehab environment in a non-COVID world. And so the way that we would approach those impairments are very similar to the way that we would treat our patients anyways in that same evidence-informed or evidence-based practice. However, we are seeing some different trends that are unique to the presentation of post-COVID-19 patients. And there has been a global consensus that there are 5 specific pillars that need to be screened and continuously monitored throughout a patient's journey in the rehab continuum. So we're going to run through all 5 of those so that it kind of sets the stage to better understand where the treatment recommendations from AHS are coming from. So the new considerations that will impact clinical decision-making in our allied health world will be post-exertional symptom exacerbation, cardiac impairment, significant dyspnea, exertional oxygen desaturation, and dysautonomia in orthostatic intolerances. So just like Laura said, like there's tons of stuff out there and you're reading social media and you're reading the media and it's everywhere. And it's really hard as a clinician to try and synthesize what you're reading, who we're talking about, how that applies to clinical practice, does it apply to everybody? And so just like maybe to help categorize kind of the general syndromes of what we're seeing in a post-COVID or long COVID world, the National Institute for Health Research has presented that there's grounds to support that long COVID is an umbrella term for up to 4 different types of syndromes. And so there is the syndrome of permanent end organ damage. So that might be like pulmonary fibrosis, which we see in pulmonary rehab, stroke, cardiomyopathy, or an acute kidney injury that might happen while in-house. Then we've got our post-intensive care syndrome, which as rehab professionals, we're quite familiar with PICS, and that's going to present like with severe hospitalizations, critical illness, myopathy, neuropathy, cognitive dysfunction, PTSD, maybe upper airway dysfunction from tracheotomies or intubation. It's not an exhaustive or comprehensive list by any means, but it's just an example of kind of where other groups of patients may be suffering from long-term effects or long COVID. The other category is post-viral fatigue syndromes. And we've heard of this before in other viruses that have gone around like West Nile virus, but the hallmark symptom of post-viral fatigue syndrome is post-exertional malaise or symptom exacerbation, which we've often heard associated with the chronic fatigue population. It's also characterized by exercise intolerance or symptom deterioration when faced with exercise or activity. And then it's also characterized by relapses or crashes. And then you've got that other pillar or syndrome of long-term COVID. And those are those non-specific kind of, you don't know where they're coming from, what the etiology of them truly are, but those non-specific persistent symptoms like shortness of breath, headache, sore throat, dry cough. And we don't quite know what the etiology of those are, but they're kind of off in this other syndrome. So just to try and help categorize. So the first one is post-exertional symptom exacerbation. And this probably will have the most impact on clinical decision-making for rehab professionals when we're trying to prescribe interventions. But it's defined as a triggering or worsening of symptoms following physiological stress and or cognitive activity. And other hallmark features is that it's activity or it's a stimuli that an individual is historically able to tolerate. It's not relieved with rest. The response and fatigue is disproportionate to what the activity really was. And it has that 12 to 48 hour delayed onset of fatigue or symptom worsening. In a survey that was done of 3,800 patients who had illness duration of greater than 28 days, 3,600 of them responded yes to experiencing worsening or relapse of symptoms after physical or mental activity, which is a huge proportion. And at the 6-month time frame, the top 3 symptoms people were reporting were cognitive dysfunction, post-exertional malaise, and I don't want to lie to you, fatigue, unsurprising. So it is affecting people for quite a long time, and the longer it goes on, the more likely some of this will be present. And I think it's also really important to note that a huge proportion of this population, so 45% of people that did that survey, are on a reduced return to work schedule or doing accommodated duties, while 22% have been unable to return to work. And that's a byproduct of not being able to tolerate that stimuli. So if we're looking at rehab implications, this is an example of how post-exertional malaise may start, how long it lasts, how severe it is, and what is triggering the onset of it. And so if we look at the top 3 triggers for post-exertional malaise or symptom exacerbation, it's exercise or mental or physical activity. And so as rehab clinicians, that's very important for us when we're trying to assess what is the most appropriate intervention. So being able to tease out if your patient does in fact have post-exertional symptom exacerbation will be critical in being able to tailor an appropriate intervention. And the recommendation is that whatever intervention is provided, if your patient is presenting this way, is titrated below the level of symptom exacerbation. And so we've heard exertional malaise much before, definitely associated with chronic fatigue or myalgic encephalomyelitis. The reason that symptom exacerbation is being used is because malaise is often nonspecific or often associated with fatigue. But what we're seeing in this post-COVID-19 population is that stimuli is starting to cause reoccurrence of viral symptoms. So that shortness of breath may worsen, or you may have more of a sore throat or a headache. And it's not just fatigue, it's recurrence of viral symptoms. So that's why the language is a bit different. The good news is that over time, it does look like symptoms are gradually getting better with some people in this population. But again, you do have that small group that will perhaps not get better and need to have a little bit more specific coaching. And then in light of that, because there's such crossover with this presentation with the chronic fatigue or myalgic encephalomyelitis community, their organization has released a new statement for clinicians, basically indicating that graded exercise therapy or our traditional overload principle may not be appropriate and actually may be detrimental or counterproductive when treating these people. So it's just something to keep in the back of our minds as a very significant pillar and a significant group of the population that may present this way. The next kind of pillar of impairment that we need to screen for is cardiac impairment. So there was a study done of hospitalized patients, and the rate of cardiac injury was quite substantial at greater than 20%. And then in another study of non-hospitalized and otherwise healthy individuals, there was mild cardiac impairment present in 32% of individuals. So we know it's there and we know that it's happening. And so in a rehab context, of course, that's very important when we're thinking about prescribing exercise at a therapeutic intensity. So some of those cardiac impairments may be myocarditis, pericarditis, arrhythmias, thromboembolic disease, or heart failure. And it's not necessarily a red flag, but the way that those things may present are palpitations, inappropriate tachycardia, chest pain, marked reduction in fitness, and disproportionate breathlessness to activity. So it is a red flag in a way that if someone does have a cardiac impairment that has not yet been flagged out, that needs to be done. But it's not a red flag that we won't intervene. But it's again about trying to interface with primary care to have the appropriate diagnostic so you have a clear diagnosis of what you're dealing with in terms of being able to make sure that patient is accessing the most appropriate therapeutic intervention from the most appropriate service. And people may come to you cleared, and in those circumstances, you have the information that you need. But if you're seeing cardiac symptoms, it's definitely something to interface with primary care about. Significant dyspnea is also something. So we know that a massive amount of individuals are demonstrating long-term respiratory symptoms. And so that can be shortness of breath, that could be chronic cough, chest tightness, wheezing, some of those non-specific, but quite impactful symptoms. And so you can go to the next slide, Laura. I know that in my line of work in pulmonary rehab, an individual's breathlessness has a significant impact on their ability to not only participate in rehab, but also participate in their own lives. And it presents quite a significant participation restriction. And so being able to manage that breathlessness or that dyspnea is quite important to be successful in rehab. And this is just a really busy picture of all of the different, and again, not comprehensive, but possible etiologies of where dyspnea could be coming from. And what you'll see in teal is the therapeutic endpoint can be very different depending upon why dyspnea is in fact presenting. And so there are some very straightforward reasons why people may be short of breath, and that's deconditioning. And as therapists or rehab clinicians, we know how to manage that quite effectively and independently. Or maybe somebody is demonstrating a breathing pattern disorder, and so you're looking at breathing retraining, and it's pretty low risk, but people also present with dyspnea or shortness of breath as a byproduct of thromboembolic disease, heart failure, respiratory disease, or upper airway injury or dysfunction, which can be progressive and potentially life-threatening. So if your patient is presenting with dyspnea, being able to tease out where that's coming from is going to be critical in terms of patient safety, but also making sure that they're getting, again, the appropriate therapeutic endpoint. So this is, again, just like a cleaner way of looking at it, that you want to have your etiology of breathlessness to drive therapy and the intervention individuals are going to receive. Even if it's from the same clinician, you want to make sure that you're using the correct tools. And sometimes, again, if you're not sure about why that breathlessness is present, interfacing with primary care for the appropriate diagnostic workup will be critical. And so just as an example, if someone has respiratory disease, pulmonary rehab is a very effective and indicated rehabilitation tool. However, if someone's presenting with breathlessness and it's secondary to an upper airway dysfunction and that hasn't been teased out yet, pulmonary rehab is not an appropriate place nor a therapeutic place for them. So again, it's about looking at your patients and saying, what does this person need from us and how can we match their therapeutic targets appropriately? Another pillar which is significant when it comes to safety is exertional oxygen desaturation. So we're seeing in some literature greater than 4% at 1 month post-discharge. At the same time, we're also seeing this in non-hospitalized patients, and we're seeing it kind of across the continuum of rehab. It's not just on discharge. It can be developed at any point in time, and it may not be present when you're detecting it at rest. And the etiology of it, again, I will not profess to know, because I don't think any of us really know the true extent of the pathophysiology of COVID-19. In my realm, yes, we see pulmonary fibrosis as a byproduct. There is the risk of thromboembolic disease. I don't know, there might be something about red blood cell dysfunction. We don't really know, but we do know that exertional oxygen desaturation is happening for individuals, and it is happening in rehab environments. So being able to tease that out is important. And I mean, from a rehab implications perspective, first and foremost, we cannot effectively train a hypoxic or hypoxemic patient safely. You probably can't get them to an appropriate therapeutic intensity if they are hypoxic. So this is essential to tease out. And the hypothesized etiologies need to be addressed or cleared, just to make sure that any sinister etiology of it is being cleared, or it's at least being investigated and someone is aware of it. So when we talk about quantifying exertional desaturation right now, we're looking at a fall of oxygen saturation greater than or equal to 5% or below 90% for patients without lung pathology. And so there are lots of guidelines out there right now, and in the literature, you may see 3 or 4%. However, the way that we measure this is with pulse oximetry, especially in outpatient settings. And the 3 and 4% is within the confidence interval of the device. So if we're going to send somebody back for investigation to primary care, we want to make sure that there's actually a significant desaturation present. And this is in line with the American Thoracic Society position statement on cardiopulmonary exercise testing. And then the last pillar that we are seeing in this population is dysautonomia and orthostatic intolerance. So dysautonomia is a range of clinical conditions, and it's a byproduct of the dysfunction of the autonomic nervous system. So that's your parasympathetic and sympathetic systems that work involuntarily to maintain homeostasis within the body. In our post-COVID patients, we are seeing orthostatic intolerance or postural orthostatic tachycardia syndrome, or POTS, most frequently as the dysautonomic presentation. And so the orthostatic intolerance is, we've seen it lots, we're familiar with it. It's that movement into an upright position resulting in symptomatic arterial hypotension. And so the thought there is that the autonomic nervous system it fails to respond appropriately to the demands placed on an individual when they're in upright positioning. Whereas with POTS, it's a sustained increase in heart rate in an upright position without the associated hypotension. The conundrum and the importance for rehab clinicians is that with both of these presentations, other symptoms can include dizziness, weakness, pre-syncope, and heart palpitations. And so because it's hard to differentiate them from cardiac conditions, it's really important to assess heart rate parameters in individuals that are demonstrating that and monitor for orthostatic hypotension if it's suspected. And again, interface with primary care to ensure the appropriate diagnostic workup can be done. And you are liaising with them to, again, make sure that your individual is getting the appropriate therapeutic intervention. Caitlin, I will hand it off to you.
All right, thanks, Lauren. So now that we've covered the 5 main physical sequelae we need to monitor for after COVID, we wanted to introduce you to a screening tool which has been developed in collaboration with our colleagues at CAR here in Calgary. So we called this the screening tool for post-COVID physical sequelae, and you'll see that it's broken up into 5 different sections, which we'll cover in more detail because I know it's difficult to see on the screen. Before we go through the screening tool itself, we just wanted to highlight that we recognize this is it's a 2-page screen and it does take time to administer. Ideally, clinicians would go through the entire screen, but we recognize depending on your area of practice, that may not be feasible. So there is some flexibility in choosing what components of the screen to administer and when. We also wanted to note that you can administer this across the care continuum. So it can be done in acute care all the way out to community. And you may need to redo the screen depending on how your client's symptoms fluctuate during their course of treatment. The last thing we wanted to mention was that in the outcome section, we do often say if clients screen positive for certain conditions that we need to liaise with the primary care physician or specialist. And that, as Lauren mentioned, that doesn't necessarily mean a full stop to treatment. You could probably focus treatment on education and activity pacing until we receive medical clearance to progress with exercise. So with that, I'll take you through each section of the screen in more detail. So the first section we're looking at is post-exertional symptom exacerbation, or PESE for short. And the screening tool that we've selected for this portion of our screen is the DePaul Symptom Questionnaire for post-exertional malaise. This is a validated tool that's used in the chronic fatigue and myalgic encephalomyelitis population. And that's why we decided to use it for our population with post-COVID, because they've started to use it in that population as well. What you'll notice is clients are asked to rate the frequency and severity of their symptoms on a scale from 0 to 4 in 5 different symptom categories. So those symptom categories include a heavy feeling after starting exercise, next day soreness or fatigue after non-strenuous everyday activities, mental fatigue after slight effort, minimal exercise makes them feel tired, or they're physically drained or sick after mild activity. So again, they would be asked to rate their frequency and severity of symptoms from 0 to 4, and a positive score would be greater than or equal to 2 in any of those 5 domains. So for example, a score of 2 and 2 would be positive, where a score of 1 for frequency and 4 for severity would be considered negative. If the client were to screen positive, Lauren has mentioned some of the recommended outcomes, but we would suggest that activity and exercise be titrated below the level that symptoms are exacerbated. Typical graded exercise using the overload principle would be contraindicated, and we would suggest that you proceed with education, activity pacing, and energy conservation techniques. If they were to screen negative, on the other hand, you could proceed with a graded exercise approach, but it's important to note that symptoms can fluctuate. So if your client were to report significant fatigue or worsening of symptoms after therapy, you may need to rescreen them and adjust your treatment approach. The next slide here shows you questions 6 through 10 on the DePaul symptom questionnaire, and this is an optional component of the screen. You could do this for patients who screen positive, and it doesn't help you determine if they're positive or negative, but it may help you guide your treatment. So for example, as a physio, if I'm completing the screen and the client reports that mental effort makes their fatigue a lot worse, it would be a cue that it may be necessary to engage OT or other members of the care team. Sorry, there you go. The next section is around cardiac symptoms. So you notice in the left-hand column there, we have a little asterisk, and what we're trying to highlight with this is the importance of considering recent medical testing, if they've been cleared recently for activity, and their baseline status or pre-existing conditions. Because we want to think about all those factors when we're determining whether or not to send them back to primary care or their specialist. And the reason for that is we don't want to unnecessarily be burdening our physician colleagues if they've already considered those factors and done testing to clear the patient. So with the questions that we've proposed here, we're trying to capture some of those red flag symptoms that Lauren mentioned. So we ask clients if they feel their heart racing with simple activities, if they're experiencing heart palpitations, or if they have chest pain at rest or with activity. And to err on the side of caution, what we proposed is if a patient responds yes to any of those questions, we would recommend further medical testing to make sure that they are cleared and safe for activity. The next portion of the screen, is around significant dyspnea. So again, we put the same qualifying statement in that we want you to consider baseline status and pre-existing conditions when determining whether or not they need to be referred on for testing. And what you see on the screen here is an adapted version of the MRC breathlessness scale. So you would complete the scale from top to bottom, asking a series of questions. And if the client responds yes to any of the questions, you would proceed to the next grade. So the first question is, are you ever troubled by breathlessness during non-strenuous activity? If yes, are you short of breath while hurrying on level ground or walking up a slight hill? Do you have to walk slower than most people on level ground, or do you have to stop after 15 minutes of walking at your own pace? Do you have to stop for breath after walking about 100 yards or after a few minutes on level ground? And are you too breathless to leave the house or breathless when at rest? So again, if the client were to respond yes to question 2, but no to question 3, they would be considered grade 2 on this scale. If they score 4 and they're breathless at rest or unable to leave their home, they're obviously not going to be appropriate for exercise. So we would want to refer back to a physician to determine what the root cause of their breathlessness is. A score of 3 or less, we would suggest that you proceed with the next component of the screen, which is around exertional oxygen desaturation. So for the exertional oxygen desaturation component of the screen, we've recommended a few different outcome measures that you can choose from, depending on clinician time and what you feel the patient can tolerate. So the outcome measures we recommend would be the 1-minute sit to stand test, the 2-minute step test, or the 6-minute walk test. SpO2 should be monitored throughout the test and for at least 1 minute post. And as Lauren mentioned, our definition of exertional oxygen desaturation is a drop in SpO2 greater than or equal to 5% or below 90 for patients with no known lung pathology, or 88 for those with known lung disease. Again, if they were to screen positive, we would want to understand what's causing their desaturation. So referral back to primary care or their physician would be recommended. And if they've been medically cleared, your treatment approach may vary and you may be focused more on activity pacing and symptom management. If they were to screen negative, again, you could proceed with treatment as usual. But just be aware that exertional oxygen desaturation can present at any time, so you'd want to monitor and rescreen as appropriate. The last component of this screening tool is around dysautonomia. And we do recognize that all of these screens take time, so we put in a few qualifying questions, which will help you determine if further investigation is needed. So we first ask the client if they feel lightheaded after a change in position, or if they feel unwell when sitting upright or standing. If they were to reply no to both of these questions, no further testing would be required. But if they respond yes to either question, we would recommend you move forward and complete an active stand test, which helps us to screen for orthostatic hypotension and postural orthostatic tachycardia syndrome. So during the active stand test, you'd want to monitor blood pressure and heart rate after 5 minutes in supine, immediately upon standing, and at 2, 5, and 10-minute intervals. OH would be defined as a fall in systolic blood pressure of greater than 20 or diastolic blood pressure greater than 10 from baseline. And POTS would be defined as a sustained elevation of heart rate greater than or equal to 30 beats per minute from baseline, or greater than or equal to 120 beats per minute in the first 10 minutes of being in an upright position. If your patient screens positive for OH, your treatment could continue. You'd want to provide education, and treatment would be more focused around symptom titration. If patients screen positive for POTS, on the other hand, as Lauren mentioned, we would want to refer back to primary care because this can present similar to many other cardiac sequelae, and we want to make sure that patients have a proper diagnosis and are receiving the most appropriate therapeutic intervention. So that's the screening tool, and I will mention it is meant to be administered by clinicians, and again, depending on how the patient presents, you can kind of pick and choose which components of that screen to administer and when. The next thing we wanted to do is just highlight some of the resources we've developed to help supplement the webinars and the screening tool, which we just discussed. So this is the Rehabilitation and Allied Health Practice Considerations document. And as Laura mentioned earlier, this is meant to be a multidisciplinary document that looks at all of the common sequelae after COVID, where our treatment might differ. So we look at different categories, including supporting self-management, screening for red flags and referrals. We look at the 5 physical sequelae we've talked about today. And then we get into some more specialized areas. Some patients are presenting, for example, with incontinence after chronic cough. So we touch on pelvic health issues. And then our other colleagues from our allied health teams have pulled together some content on maximizing energy, cognition, and there's some sections under development around speech, eating, feeding, and swallowing, and the psychosocial spiritual impacts of COVID. We also wrap up the document with a small section that helps people in terms of caseload management and prioritization, more from the outpatient side of things. But it just is meant to help guide clinicians, as we know it's difficult to prioritize COVID patients in and amongst your regular caseload. I will just say with this document, it's not meant to be an all-inclusive list. Some people have asked why neurological sequelae aren't listed here. And the reason for that is, again, we wanted to focus on areas where treatment would be different. And we felt that for the neurosymptoms, our treatment approaches would be very similar, regardless of whether it's a regular patient or a post-COVID patient. I'll also just mention that we realize there's new and emerging evidence all the time, and we will do our best to keep these resources up to date. And new versions will be released as research emerges. So in terms of where to locate these resources, there's a few different options. We have a post-COVID provider resource webpage, which was launched yesterday. And there's a link to that for you here. We also have for AHS staff an Allied Health Practice and Education Hub, which includes the clinical resource document, the screening tool, and both of these links will have recordings of our webinars and PowerPoint presentations. If you have any questions about the material, you can certainly email practice.consultation@ahs.ca. And then before we wrap up, I'll just have you go to the next slide, Laura. Just wanted to highlight a few of the additional webinars that we have coming up. So again, there was a kind of an overwhelming response to the session we did on Tuesday, which was a repeat of this session. So we decided to move to Zoom as our platform. And these sessions will run for the next 6 weeks from 11:30 to 12:30 using the same Zoom link you used to access this session today. And just wanted to highlight the session next week, which will be provided by our OT colleagues who will speak to maximizing energy and returning to daily activities and meaningful occupations. So with that, I think we can go to the next slide and we'll open it up to the group for questions. I think Stephen has the questions pulled together and he'll moderate this section of the presentation.
Sounds good. Can you hear me? So we do have a number of questions already, and we'll invite, if you have other questions, if you can direct message those either to questions or to Allied Health Education, we'll do our best to answer those. So the first question is around exercise and prescription. Is there any research based on how to progress exercise? The activity should be below symptoms to trigger, but is it expected that you can increase that intensity of exercise as you're going and not trigger those symptoms? So probably Lauren, if we can start with you and just any suggestions on that question.
Yeah, definitely. Yeah, for sure. Great question. Yeah, it's a really fine balancing act, and we've seen that a lot across clinicians talking about this globally. Is, you don't want to provide overload principle to people that are suffering from post-exertional symptom exacerbation, but you simultaneously don't want to undertrain an individual who's capable. So I guess it comes from that perspective of teasing out whether or not someone's symptoms are being exacerbated by activity and titrating activity below that level of symptom. But if they're progressing appropriately and responding to exercise appropriately, by all means, then I think that there's indication to increase the intensity of it and grade it. We tailor exercise to patients all the time, tailor it to what people can tolerate. Obviously, if they have DOMs, like 3-5 days after the fact, that probably was too much. But, it's teasing out that, do they have symptom exacerbation, and are they having symptom deterioration, and is it lasting for a prolonged period of time and not relief by rest? So balancing act, trying to tease out that. And the other interesting thing about the post-COVID environment is that people are on this healing timeline, and it might take a while. And so, 6 weeks after infection, they might still have exertional symptom exacerbation. They might still have a headache because they've done too much. And at that point, rest becomes the indicated activity, because there's no point in overloading at that. But if someone is adapting well, then by all means progress. So that's kind of the recommendation right now, is that balancing act. I don't know if that helped or raised more questions, but some of that.
And I think just to add to that, Lauren, we do our session on the 22nd. We'll get into more detail around, what's the difference between activity and exercise. And I think at that point, we will be able to dive a little bit more in depth into the treatment recommendations. But in the meantime, I think people can look through that resource document, because there is a section under each sequelae, there's a section about treatment recommendations and our recommended outcome measures and that type of thing.
Mm-hmm.
Great. Next question is also a clinical one. How can we identify patients that might have post-exertional symptom exacerbation even before we start intervention? How can we streamline our assessment in acute care to set up to identify such clients with that potential issues? So that's the start of that question.
Okay, from an acute care perspective, I think it'll be really difficult to see who's going to have symptom exacerbation. I'm not sure that there's really a lot of predictive information about saying, this population is going to be more at risk. I think we've seen in social media that they're saying really type A, high-strung people are presenting more with that, but that also might just be a bias of who's seeking care. But I think the timeline, it's hard to predict who's going to have it, but if people are giving you that description in the history that you're getting, they're having a hard time recovering, they can't handle the normal activity they historically did, then I don't think overload would necessarily be the most appropriate place to start. But currently, there's not really a lot of predictive information in acute care. I think one of the big things that we've talked about is that idea that rest is an activity. And if people need to recover coming out of hospital and going home, that should be a focus. And I think there's a general like low intensity physical activity recommendation, but they need to be assessed by somebody if they're struggling. But yeah, I guess that's where the tool comes in to help screen out whether or not people are being able to recover.
And I think you'll get a sense of that too, like from an acute perspective. That was my background originally. And I think, you know, from day to day, like if you get a patient sitting at the side of the bed one day and the next day it's very obvious they're wiped from that and they didn't tolerate, then I think those are kind of your signs. So recognizing it's tough to go through a full screen, you know, you might just have to kind of take it day by day and see how patients present and see how they respond. Because we do know it fluctuates, and what they tolerate one day, they might not tolerate the next. So I think you just need to be flexible in your treatment approach.
Great. Next question is also on treatment. How do you tease out anxiety as a potential key cause for increases in heart rate and breathing rate? And does that change how you treat?
It's a tough one. I'm not going to profess I'm a physical therapist, so I'm not going to answer the question about how to tease out anxiety. And I think it's if someone is from my lens, if someone is presenting in a breathless presentation, it's making sure that the red flags, you know, exertional desaturation or pulmonary disease as a byproduct is ruled out, or cardiac disease is ruled out. And if you have those sinister causes of breathlessness ruled out, then it might be easier to kind of look at how to intervene. Ultimately, if someone is actually presenting with anxiety, that you're going to need a multidisciplinary team to be able to intervene. And you can still manage the breathless patient from a breathing retraining perspective, but I don't feel like I would be the most appropriate person to answer about teasing out anxiety. But I would want to rule out like sinister causes.
Perfect. No, I think that's a great answer, and we've got some sessions coming up to deal with more of the psychosocial side of COVID recovery. So I think maybe we'll hold that thought and have more information coming in future sessions. Next one, has Appendix A been piloted across all care streams in long-term care and supportive living? So Caitlin or Laura?
I can jump in there. The answer would be no. We, again, have been trying really hard to pull together resources quickly for clinicians, and developing the screening tool was a bit of a process. So no, it hasn't been tested or piloted. And I think that's where we'd be curious to have feedback from people who are actually trying to use it. We tried where possible to make sure that we were using validated outcome measures in our screen, but I think that's another piece to note, is that because COVID is so new and it's constantly changing, I think a lot of the tools haven't been validated in a post-COVID population. They've been validated in other populations that we felt were similar. So hopefully that answers that question.
Great. Another question around acute care. Can the screening tool be used in acute COVID care and post-ICU intubation with post-ICU intubation clients?
Good question. I'm like open and I'm like closing and I'm like, in theory, I think it would be really difficult to tease out post-exertional symptom exacerbation in this population. Just from like my experience in acute care, especially if people are demonstrating a PICS way because their exercise tolerance is so low and you are titrating activity to what they can currently do. There is a recommendation from the European Respiratory Society that individuals post-COVID and definitely post-intensive care be screened for exertional desaturation prior to discharge. That's a really important piece to help connect the transition piece. Caitlin?
Yeah, I was just going to say, I think the acute population is certainly more challenging. And I think we realize that the tool may need to be tweaked and adapted depending on how your patient presents. We just wanted to make sure that we had those broad themes out there so that clinicians were thinking about it. But I think in acute care, it's a little different because you have a very supportive team around you. So, if your patient's presenting with desaturation or cardiac type symptoms, usually there's a medical team that you're meeting with regularly, and you can kind of talk through that and decide whether or not they need more evaluation or not. So you might not go through like the formal screen in detail with those patients, but again, we just wanted to have those concepts out there, and it's a tool that you can use to support yourself in practice. I don't know if that is right or wrong, Lauren, but
I don't think it wouldn't. I don't think any of us know.
Next question is from one of our respiratory therapists. I see the sickest of the sick are the patients that are referred to you in that mild, moderate, or severe category, or a mixed bag. And I think the question is really, does this work for sort of everybody on the continuum, and it's an approach, or is there any sort of guidance depending on the severity of the client, and does your approach change?
I guess I don't know, like, is this like an outpatient setting or an inpatient setting? I think it could work across the continuum. Like Caitlin said, there's some clinical decision making and judgment with the tool and looking at the pillars that we know might present. And I think if you think that some pieces are applicable, then use them. I think if it's clear that some of them aren't presenting and they're not reporting any symptoms, then I think you can leave some of those pieces behind. But Stephen, I might be missing some pieces in what's the question's asking.
So I'll check back and see if the person that entered that question has anything they want to clarify. I think in terms of sort of the presentation and the folks that you see in clinic, are you seeing the gamut of people that have had mild disease to severe disease to, our ICU intubated graduates?
Yeah. Okay. Yeah. So we're seeing, from my lens of pulmonary rehab, we're seeing the people that are demonstrating moderate to severe pulmonary disease because this would be indicated. But we are seeing in those patients that we're seeing other comorbidities that are coming from that COVID diagnosis, like long-term myalgias, which obviously that causes chronic pain, which complicates the way that we intervene. You also have an acute change in life status. So there's a whole host of other things that you're trying to address simultaneously. And then there's also like upper airway dysfunction because of repeat intubation, extubation. So those people are kind of presenting a little bit more comorbid from a respiratory perspective than they normally would in our clinic presentation in non-COVID patients. I think another really important piece to recognize is that the severity of your acute infection doesn't necessarily drive the degree of debility that people experience in a post-COVID environment or that subacute environment. Is like if someone is really, really sick in-house, that doesn't necessarily mean that they're going to be the people that are long hauling. It's some people that have mild infection at home are like mild symptoms at home are experiencing long-term disability. So there's kind of this incongruence between the severity of acute infection and what their long-term rehabilitation needs are. So I think the tool offers some good insight to use across the disciplines and across the timeframes of people's rehab experience, but it's a bit broad. It's hard to know anything really.
Perfect. And I think you just answered another question in your response there. The question was, is there a correlation between severity of the initial disease and kind of the more severe sequelae? I think you just answered that. Not necessarily. There's a variance between what happens in the disease severity and the symptoms later on. Is that correct?
Yeah, I think it depends though on if someone has a severe hospitalization because of COVID and they have a hard time with COVID, it means that they're probably going to have, a post-intensive care presentation. They might have upper airway dysfunction. They might have that long-term PICS presentation, which is, of course, is extremely debilitating and really difficult for individuals in a massive life transition. And so the severity of those symptoms downstream can be quite significant. However, when we're talking about the long haulers of, post-exertional symptom exacerbation and long-term fatigue and an inability to return to work from that kind of mild acute infection, we're also seeing that. So again, yeah, you're right. It's like, it's not it's just it's all over the place. But I think there is some commentary, and I think it's important when we're dealing with patients, especially long haulers, is to validate that experience, because oftentimes they're met with, oh, I had a mild infection at home, or I was only a little bit sick, and so people think that they couldn't possibly have long-term issues, or their infection was somehow lesser than others. And so it's understanding that the trajectory long-term, even for people that had mild acute infections, can be quite devastating.
Great. And then I think we have one last clinical question. In regards to progressing exercise, do you have a preferred approach, focusing on one parameter than another, i.e. progressing intensity, then volume, then duration, then frequency? Or is there any formula that you use in your setting?
No. I think there's like, your general rehab principles, and we try and progress people the way we normally would in pulmonary rehab. But I think with the post-COVID patient, we don't know. And I think titrating below symptom exacerbation is like of primary importance. And then I think you load or progress people as you see fit. And if that's volume and that's what they tolerate best, great. If it's frequency, great. And we're seeing in the dysautonomic population, it's that change of supine to recumbent to seated to upright. And so there's all different ways to progress exercise. So I will not profess to have an effective formula. I think it's just trying to treat the person in front of you and titrate delivery to what is in front of you.
And I'll maybe just add to that, Lauren. I think one piece that we didn't mention today, but as part of the ECC task force, Chester Ho is working to pull together a group of clinicians to help create an expert consensus panel for the province. And I think it'll include physicians and rehab staff from Alberta as well as outside of Alberta. And I think we certainly don't mean to say that the resource we've released is 100% what you need to do. I think we realize that there's emerging evidence and lots of changes happening. So that's a group that we plan to lean on as we continue to update our resources. And we're hoping, especially around the cardiac piece, that some of our cardiac physicians may be able to weigh in terms of what parameters we need to look for, what are our target heart rates and stuff like that in this population. So there's still work to come in that area.
All right, that brings us to the end of the clinical questions. The last question was, where can I find these resources? Those links that are in the instant message right now are the correct links. We don't have exactly worked out where the resources will be and where the recordings will be, but you will be able to find them on that public site and on that second AHS employees only SharePoint site. So watch for those in the next week or two, and definitely the links will come up. We also invite you to watch for the other sessions, look for the other sessions, and even if it's not your primary area of practice, really encourage you to attend sort of a holistic approach, or take a holistic approach to this care, to the care of this group, and consider some of the topics that might not be your primary focus in your role. With that, Lauren and Caitlin, I'll pass it back to you if there's anything else you want to say to close us out.
No, just thanks everyone for joining today, and we're looking forward to seeing you again next week.
Thanks, everyone.
Bye.